Hi, this is Dr. Torino at EVMS, and I'm here with UltraSoundbytes discussing transvaginal scanning today. We're going to today talk about the clinical application of transvaginal ultrasound machine and probe setup, the acoustic windows, acquisition of images, and pearls and pitfalls. So the real purpose for this exam is to assess the uterus and the adnexa, and you can rule out a uterine mass like fibroids, a pregnancy, intrauterine or not, to rule out adnexal mass or cyst, and these can be very important. The thing that makes this a little bit better for determining things like gestational age is you can have a higher frequency because you're closer to the uterus. So for our machine, of course, if you were doing this in clinic or in lab, you would set it up as you are instructed to, but your preset will be either GYN or transvaginal, and your probe selection would be the transvaginal probe. Everything else is going to stay neutral until you're scanning. Probe prep is going to be very, very important, and this is a very involved discussion that you should look into before you begin scanning. High-level disinfection is required between patients. Also, ultrasound equipment cannot be heat sterilized, so this is a soak or a wrap in a wipe. If you wrap in a wipe, you must leave it in a damp wipe for up to 3 minutes. So you should read your manufacturer, you should follow those rules. They don't like us to use alcohol-based wipes because it can degrade the lens coating on your probe. You are going to cover your probe with a condom or an ultrasound probe cover, and I will show you how to do that properly. When you're done scanning, you will remove the probe cover just with your glove in one swoop to take it off. You will wipe your probe clean and then disinfect it. As you're prepping your probe to begin scanning, you've got to make sure that you get rid of air bubbles, because that would be really detrimental to any diagnostic decision making you have. And so you're basically going to put gel on the probe, then a probe cover, then sterile gel on the probe cover tip, and then you'll be scanning. I'd like to go to my probe now and show you how we're going to do that. I have a probe cover, some gel, and my probe. So the first thing I'm going to do is non-sterile gel goes onto the probe or inside the probe cover, depending on how you approach it. I'm using my probe cover. I'm going to drape it over the probe till it gets to this, the probe kind of ridge, which helps keep that in place. Many probe covers come with a small rubber band to help it stay. I prefer not to use that. Then you're going to take the gel and you're going to just gently make sure that any small air bubbles have been eliminated. Then you would take sterile gel and put it on top of the probe cover. I'm scanning a phantom today for you, so I'm going to use non-sterile gel. So I have non-sterile gel. I'll go back to my notes for just a minute, please. So we're going to keep our probe marker similar. But the thing is, you're not facing superiorly, you're facing more anterior. And each probe has a groove, let me get there, a groove, and this groove represents a sagittal orientation. And then when I rotate my probe counterclockwise, the ridge, which is my thumb marker, goes still to the patient right. So it's standard orientation, except now marker is up or to patient right, counterclockwise. All right, perfect. Thank you. When you're scanning, you need to be able to move the handle of the probe quite a bit, and so you would often put your patient either in stirrups or with a bolster under their hips so that you have enough room to do so. So there are some images here, and we're going to do this in real time, but what I want you to see is basically you're sweeping through the uterus and adnexa in sagittal and transverse scan planes. Once you begin scanning, of course you're going to have to make all your adjustments to see what your image needs. But one of the things that I'm going to review with you, remember, whatever way you're turning, the handle's going the other way. And I'll show you that right now, please. So now we're going to go to our phantom, and I'm going to begin scanning with the marker anterior facing up with my thumb holding it. Now remember, many of you will come into lab and practice, and be careful. These phantoms are very delicate, and you don't want to push hard enough to displace the pins that hold the uterus in place. So I'm going to start just midline, however the probe it falls into, in this case, the phantom. And what I want you to remember is that on a normal patient, that fundus of the uterus is going to be quite anterior. To go anterior, I'm going to make the handle of my probe come posterior towards the bed. So handle goes down, and my probe tips up, and I can see now uterine fundus. If my handle comes up, now I can see deeply posterior structures like the cervix. As we scan side to side, if I move the handle towards me, we're going towards the patient's left. As I move the handle away from me, we're going towards the patient's right. Then I'm going to come back to my midline, and I'm going to rotate the probe counterclockwise. Again, now I'm going to handle up, and I'm going to look posterior to see cervix, and I'm going to handle down so that I go through uterus, and hope on this phantom I'm not going to be able to get all the way up to the fundus. Handle towards me for left ovary and left adnexa. Handle away from me for the ovary near me, right ovary, and the adnexa. So my probe handle is continually sweeping. And usually when I start scanning, I'll tell a woman, you're going to have about this much insertion and all the rest is handle. So remember, most women are going to be nervous and a little bit scared. So coming back to our presentation, this is where we ended. Again, the reminder, however you move the handle, your probe elements are firing in the other direction. What are some pitfalls? The big two. The first is the movements are big. People are surprised and a little uncomfortable the first time when you realize how much you have to move the handle. So be prepared for that. Also, please remember there's a patient, there's a woman behind that probe. Tell them what you're going to do. Patients will let you do almost anything if you explain what and why you're doing it. So think very carefully about what you're doing. Your clinical pearl. Why do we do transvaginal scanning? Because we can see smaller resolution, and that means we can document pathology earlier, intrauterine pregnancies earlier. So you want to really get away from the need to have a full bladder, to have a bowel gas that is interfering, and this can help you. The other thing I'm going to give you as a clinical pearl has to do with ovaries. Ovaries can be so tough to find. You really want to, first of all, hope they have follicles. But secondly, when you move your handle out laterally, either towards you or away from you, look for the iliac vessels. And the ovary should be sitting near the iliac vessels. Will they always be? No. They can be just about wherever they want. But start there. Artifacts are going to be the same artifacts we're used to seeing. Some posterior enhancement, some posterior shadowing, some dirty shadowing, and edge artifact would be probably the most common artifacts you will see. And now I'm going to move to my SPI snapshot. Today I'd like to talk to you about transducer construction. We kind of take everything for granted, but there's an awful lot going on. You have some sort of lens, some sort of coating, and then a lens. Then you have matching layers. Matching layers help sound get into the body. You have elements. You have hundreds of elements. They all have some electrical wire that runs to them. And then you have the stuff back here called backing material. This is rubbery stuff that makes sure sound doesn't come into the probe and then back out and give you an artifact. And it also makes sure our pulse stays nice and short for very good resolution. And then all of this connects via the cord to our machine. The whole thing's insulated. What do these things mean to you? They mean this is the most expensive single component of your machine. Don't drop it. It also means you don't get to heat sterilize any probe, because then these elements will not create the sound that we rely on. So think about what's inside those probes as you handle them, and remember that they each have very, very specific components, and they're all different manufacturer to manufacturer a little bit. If you're doing this as part of a lab, you're probably going to get an image, a longitudinal image of the uterus, and measure it. But if you're doing it clinically, then you would have some specific requirements. You're just going to look to your preceptor or blackboard for the correct labeling and the correct goals. Just remember, nothing is anonymous. A name, a number, some anatomic identifier should be the things that you strive to have on your image every time. Your last clinical pearl, look at the endometrium. Pay attention to it. It'll tell you a lot about the patient's hormonal state. So, an endometrium will be different from a prepubescent to a menstrual to a post-menopausal woman. An endometrium will also be different cyclically in the same woman. And during menses, it's going to be very, very thin, just almost a line. As it begins to prepare for ovulation and eventual acceptance of an oocyte that, for implantation, it gets quite thick, quite hypoechoic. And then just before menses, it becomes more hyperechoic as the blood is preparing to slough away. So pay attention to that and always ask your patient where they are in their cycle. The one normal variant I'd like to mention are Nabothean cysts. Nabothean cysts are very common. Women often have multiple Nabothean cysts. They don't go away, they just are there. They are just retention cysts within the cervix, and they are not considered pathologic or bothersome. That is it from me. I want to thank you for coming to this episode of Ultrasound Bites from EVMS. More will follow. Thank you.